trickle in. Hello and welcome everyone to the Stimulant Use Disorder Practice Update Provincial webinar hosted by the BC Centre on Substance Use. My name is Rebecca Anthony. I'm the Program Manager for the Education and Implementation team with the BCCSU, and I'll be introducing today's webinar. A couple of housekeeping pieces for today. This webinar will be recorded for later viewing. If you have questions throughout the webinar, please enter them into the Q&A tab rather than into the chat. In the Q&A tab, you can also like other questions to upvote them. We will address questions from the Q&A tab and those submitted through the registration page after the presentation today. Before we get started, I would like to acknowledge that the BCCSU is headquartered on the unceded and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And I'm personally calling in today from the traditional homelands of the Squamish, St'át'imc, and Lil'wat peoples. I'd like to next introduce our speakers. I have the privilege of sharing a screen today with some wonderful speakers. And I'd like to give them a moment to introduce themselves and say something about themselves. We'll start with Dr. Bach.
Thanks, Rebecca. Hi, everyone, and thanks for making the time today. My name is Paxton Bach. I'm an addiction medicine physician at St. Paul's Hospital. On the inpatient side in the Rapid Access Clinic there, I am also the co-medical director of the BC Centre on Substance Use and one of the contributors to this update. And again, I'd just like to thank everyone for attending and acknowledge the team that has put a lot of work into putting this document together. So I look forward to the session today.
Great, thank you so much. Kat, would you like to introduce yourself to the group?
Sure. My name is Kat Kiju, and I am calling in from the traditional territories of Lheidli-T'enneh, which is also commonly known as Prince George. And I come here as a person with lived experience to share my knowledge and expertise with everyone here. Thanks.
Excellent. Thanks for joining us today, Kat. And over to you, Dr. Elefante.
Thank you, everybody, for coming, and thanks for inviting me to talk. My name is Joseph Elefante. I'm a concurrent disorder psychiatrist who works at St. Paul's Hospital. I'm also the medical education lead for the BC Mental Health Substance Use Services.
Excellent. Thank you so much for being here today. Unfortunately, Sean Wood has not been able to join us today. So I'll hand it over to Paxton here to go ahead and introduce the agenda for today.
Wonderful. Thanks, Rebecca. So again, just want to thank everyone for making the time today. This is the practice update that we're going to be talking about. I hope that everyone has managed to obtain an electronic copy of this. It is available on our website. This was a collective effort by the medical writing team at the BC Centre on Substance Use, as well as contributors from around the province. It's not a comprehensive guideline in the same way that some of our educational materials are, but is meant to provide sort of an update on the current status of stimulant use disorder and some trends and treatment options. So this is what we'll be discussing today. The presentation and the document itself are divided up into two parts. The first is an update on evidence-based treatment options and a little bit of recommendations that are grounded in current literature. And part two is more of an exploration of current experiences with risk mitigation prescribing or safer supply prescribing, as well as some discussion on recommendations and approaches in that area. So Dr. Elefante is going to take the lead on the first half. I will speak to the second piece, and Kat is going to chime in with her own experiences throughout. And we have an hour and a half together, so should have plenty of opportunity for discussion and Q&A at the end of the session. You can type your questions into the Q&A box at any point in time, but we'll try and save that discussion until the end. I would just start by introducing the topic as a whole, just mentioning that as we're all aware, stimulants are some of the most common illicit psychoactive substances used both around the world as well as in British Columbia. The category of stimulants obviously extends from everything from caffeine to bath salts, but we're going to be speaking fairly specifically to cocaine and crystal meth use today, by far the most predominant unregulated stimulants used in British Columbia. And I'll just mention, again, this is not, I'm sure, news to much of our audience, but stimulants, this is becoming increasingly important for a variety of reasons. We're seeing increasing use over time in the province. Increasing co-use with opioids is becoming very common. Some have termed this the fourth wave of the overdose crisis. The rates of methamphetamine involvement in overdose deaths have been steadily rising. In addition, we also know that a significant portion of the stimulant supply in BC is at risk of contamination with fentanyl. Drug checking data is usually anywhere from about 2 to 5% of stimulants checked have contained some amount of fentanyl, and we're seeing plenty of overdoses from people who thought they were using stimulants and were inadvertently exposed to fentanyl through that route as well. So a variety of reasons. I think this is really topical, and I'm happy everyone's here today. So again, we're going to kick off here with a discussion more around evidence-based treatment options and information on managing stimulant use, both acute and longitudinally. And then we'll get into part two, talking about clinical experience and preliminary data from risk mitigation prescribing. So with that, I will turn it over to Dr. Elefante.
Thank you very much, Dr. Bach, for the introduction. For this part, we'll be talking about the current treatment options for stimulant use disorders and related conditions. I'll be going over stimulant intoxication, as well as stimulant-induced psychosis, withdrawal, and some of the pharmacological and non-pharmacological treatment options for stimulant use disorder and related conditions. First off, for acute stimulant intoxications, these are the signs and symptoms that are described: agitation, sweating, abnormal movement, elevated blood pressure, paranoia, skin picking, psychosis, mania, chest pain, and severe delirium. As there are no specific medications currently for treating stimulant intoxication or overdose, these symptoms are primarily managed with supportive therapy. This may include a supportive and conservative environment, or providing a low stimulus environment, and perhaps benzodiazepines as needed. These are some of the common symptoms of stimulant-induced psychosis. People may have delusions of persecution. They might have hallucinations, agitation and anxiety. They might also have some auditory and visual hallucinations, emotional activation or escalation. And they might also have impairment of judgment or insight. Stimulant-induced psychosis is relatively common. There was a 2021 systematic review and meta-analysis which found that 68% of people who reported lifetime cocaine use had experienced cocaine-induced psychotic symptoms. And a 2018 systematic review and meta-analysis of 17 studies estimated the psychotic disorders to have a prevalence of about 42.7% for those who use amphetamines. This can lead to persistent psychotic symptoms, including schizophrenia or bipolar disorder, and sometimes consultation with psychiatry might be helpful.
Do you mind if I ask a follow-up question, Julius, for you here, just to, based on your experience as a concurrent disorder psychiatrist, any suggestions on how to differentiate intoxication from psychosis, and advice based on your clinical experience as to when people should be thinking more about consulting psychiatry?
Thank you very much, Dr. Bach, for that. Yes, so it can be quite difficult to distinguish whether somebody who has symptoms of psychosis is having a stimulant-induced psychosis or having psychosis from any other condition like schizophrenia or bipolar disorder, for instance. In general, we can't go by symptoms alone, whether or not somebody is experiencing stimulant-induced psychosis or schizophrenia. So we go by history, basically. So if there's any indication that there was some recent amphetamine use, of course, that makes us think that perhaps the presentation might be more consistent with stimulant-induced psychosis. Somebody who might have had a previous history of schizophrenia might be having a psychotic disorder from psychotic symptoms from their condition, but it's difficult to tell. Usually, stimulant-induced psychosis for most people will last 8 to 10 days, maybe 30 days, or a bit longer. So they're often a little bit more short-lived. But by and large, when you meet somebody with psychosis, it's hard to tell. When I would recommend consulting with psychiatry would be when there's concern that psychotic symptoms is severe enough that they might hurt themselves or hurt other people. In that situation, I would recommend consulting with psychiatry. I'm also wondering if Kat might have any contributions to this topic, if she might have any insights into this as well.
Yeah, sure. Thanks. I think first of all, when somebody is in a state of psychosis, it's really scary in a lot of cases, especially if it is induced from like crystal meth or stimulant use. Like, it's one of two things I find with my experience. It's either you're leading up to like an overdose, right? Because you're starting to hyperventilate, freak out, maybe start thinking crazy things. Secondly, I think for psychosis, with my experience and from what I see, when somebody, like you said, over time, if it's something that we see on a regular basis that they continue to have, like it's a repetitive or it increases when they're using, then I would say that's an induced psychosis, rather than if they don't fade out of it or seeing if it's something else that like is bringing the psychosis. I don't know. I'm personally not an expert with psychosis, but this is what I've seen. I think that it's important for medical terms, if you do have somebody coming in, that maybe you can connect them with peer support and they can help build a relationship and see as well, like if that's an induced psychosis, or it's something that maybe they've known them for a long time and know automatically that no, this isn't within their character. I've known them for a long time and this is definitely caused by crystal methamphetamines or toxic drugs. Yeah, I'm not too much of an expert with psychosis that way. I do know that psychosis is very real, and I think that treating psychosis, if somebody comes in and they're in a state of psychosis, the best thing to do at that time is to like calm them down, let them acknowledge them, talk to them. Like, I think it's really important to understand that if they're like saying they see a metaphor like a pink elephant in the room, that you acknowledge that pink elephant with them, and that right there will try and calm them down a little bit and maybe open a little door to start building relationship and trust, because it's hard to trust somebody when you're in that state of mind.
Thank you very much, Kat. And you bring up the issues of safety and peer support, which are really quite helpful in understanding a patient's experience, especially when they're experiencing psychosis. Thank you. Turning to stimulant withdrawal, these are some of the symptoms that generally present a few hours or several days after somebody uses crystal methamphetamines. They might have cravings, they might experience depressed mood, they may have vivid or unpleasant dreams. Fatigue, pain, and anxiety are often reported. They can have both insomnia or even hypersomnia, so lack of sleep or sleeping too much. They might present with increased appetite, agitation, psychomotor agitation or impairment. They might present as agitated or irritable, and sometimes they might also have cognitive impairment. Currently, there are no medications approved for treating stimulant withdrawal. Treatment primarily consists of supportive care, which may include providing adequate nutrition, supporting sleep hygiene, mental health assessment, and working with the patient to identify their goals and the supports that would help them achieve their own goals. Some patients may benefit from cognitive behavioral therapy to manage their symptoms. The evidence in pharmacotherapy for the treatment of stimulant use disorders is limited and inconclusive. There are recent trials of several non-psychostimulant pharmacotherapy options, including extended release injectable naltrexone, plus oral extended release bupropion, as well as mirtazapine, that have shown some promise in reducing methamphetamine use. And there's some limited signals of efficacy suggesting further investigations into prescribed psychostimulants, among other medications. Our current evidence is limited right now, and this is because of a number of reasons. The primary outcomes might be quite strict. Usually abstinence is considered a primary outcome, and it may be too strict for many of the patients we serve. There might be limited power in the studies. The studies might be quite small, huge participant dropouts, perhaps poor adherence to the treatments. And then there's also tend to have higher placebo responses in this group. The overall result of that is that our conclusions are quite limited. These are just some of the articles that are references. Hopefully they're in your slide deck. They just talk about some of the different pharmacological options that have been studied. Medications include mirtazapine, psychostimulants, and as mentioned, bupropion and extended release naltrexone. And maybe that might be a good point to kind of ask Kat as well, if she might have some insight into pharmacological treatment of this condition based on her experience.
Yeah, thank you. I think that first of all, I'm really happy that it states goals, because sitting down and like building a relationship with somebody is key. Letting them know that you're there to actually help them, not approaching them with maybe an abstinent frame of mind, like expected type of frame of mind, understanding what their goals are. If it's harm reduction or to improve their quality of life, I think that those are wins. And if that's what their goals are, it's, work with that. The drugs are toxic out there, and it's not a matter of if they're gonna, if, it's a matter of when now, unfortunately. And it's so if somebody is willing to walk through those doors and ask for a safer supply or help, that's huge. So, and working with that person, maybe, explain to them what their options are, why these are options, what they might expect from it, or asking them, if they have a preference, or if they already know that might work for them, because for all we know, they could have tried it previously and know that this has worked, and that's why they're finally coming in. So again, really building those relationships. And I think it's important to have that support system as well, because prescription is only one piece of a big pie. So if it's possible, like having a support system with, like you said, CBT or mental health, peer support, housing, social worker to help with financial, all of these are really important support systems, like a piece of that support system that's a need for somebody to be successful, to meet their goals, whatever that looks like. And I think that was what I took for notes. I'm kind of, I'm not sure if you touched on withdrawal, but I have notes here that I think it's really important to understand the withdrawal that they might be going through as well. Because if they come in for stimulants, they might not know that they're also using benzos or fentanyl or whatever else is being used that could be cause withdrawal. So like working with them and understanding that if they're saying it's not working, or if they're hurting, because withdrawal, it hurts. It's very similar to opiates. You get you get the bone aches, you get the chills, you get the sore muscles. It's quite similar with my experience anyways. So I think understanding that and acknowledging that and seeing how you can help manage like benzo withdrawal or fentanyl withdrawal, if or whatever else is in there that they didn't know they were aware of, or they may have known. So, yeah.
Thank you very much.
If I can just make a quick plug here also for the 24/7 line. I think as Julius has mentioned, the evidence around pharmacotherapy for stimulant use disorder is often summarized as there is no effective medications, and I think that for all the reasons he's highlighted, it's really hard to conclude much from the literature either for or against. But there are a number of medications out there that are worth considering based on relatively favorable safety profiles and at least some supportive data. we're not going to spend too much time talking about this in the face of the rest of this presentation, but just to highlight that there are potential pharmacologic options out there. These are some examples of probably the more recent and more well evidence-based ones for crystal meth use. And if this is something that you want to consider adding to your practice and are less comfortable with it, please call 24/7 or call RACE. We'll have a discussion around I'm happy to talk about any of these studies in detail and when some of these medications might be appropriate. So they are relatively safe and just something worth considering in our overall approach to treatment of a really challenging set of use disorders.
Thank you very much,
Can I also make one more comment? Sorry.
Yes, of course.
I just wanted to mention as well, like if I don't agree with like being cut off or consequences for dirty drug screens. I think that that's part of the journey. And that could mean that it's just that one prescription is maybe not working for them. And maybe they might need a combination, say like methylphenidate and fast acting Ritalin or something. I know for myself, I needed that. And I think, yeah, I just wanted to throw that in there.
Thank you for sharing your experience throughout, Kat. Thank you. As mentioned, due to the limited evidence and inconclusive evidence supporting pharmacotherapy, right now psychosocial treatment is currently the standard of care for stimulant use disorder. This will include treatment options like contingency management, community reinforcement, cognitive behavioral therapy, the matrix model. There might be some peer-led support groups as well as bed-based treatment programs. And over the next slides, I'll just go over some of these. The efficacy of contingency management in the treatment of stimulant use disorder is supported by a large body of evidence. A 2018 network meta-analysis comparing psychosocial interventions for cocaine and amphetamine use found that contingency management alone or in combination with community reinforcement or CBT had the highest efficacy for achieving abstinence from stimulants. Unfortunately, there's relatively poor uptake due to barriers, including cost, practical concerns, and even some philosophical objections to contingency management. Cognitive behavioral therapy is a specialist-led manualized therapy that's been shown to be effective in reducing both cocaine and amphetamine use after treatment. Positive outcomes can happen in as few as 2 to 4 sessions. However, this does require a specialist with specific training in manualized CBT that are specific to substance use disorders. The matrix model has shown some promising results in treatment retention, abstinence, reductions in use, and high-risk behavior. And it also has led to improvements in craving management and control. Peer-led support groups can include 12-step programs in Smart Recovery or LifeBring. 12-step programs are less effective for abstinence and retention than contingency management plus community reinforcement approach. This may provide some benefit to those with previous experience or success in 12-step programs, or those who might be interested in 12-step programs. In terms of Smart Recovery, there's no evidence specific to stimulant use disorder, and most of the studies center around alcohol use disorder. There's just a question in the chat, and perhaps I'll just read that out. Do you know any specific CBT courses that a nurse, social worker, counselor can register for that are specific to substance use? No, this is an area of need actually, and I was just talking to some of the BC MHSUS people about this, that we need to develop some courses on this. Typically, what happens right now is a lot of the people who are trained in a mentorship model, so they might go to a treatment center as trainees, social work trainees or nurse trainees, and during their internship in that particular setting, they might get some exposure to CBT. There are also some books on CBT for substance use disorder itself. So some people will buy CBT manuals and read it and then try to gain experience in a clinical setting. And also Kelty's Key, somebody has also posted, has some great resources on this topic. Thank you. In terms of treatment programs, there is limited evidence on the efficacy of bed-based, or also called residential treatment models for stimulant use disorder. This is in large part due to a lack of standardization around what bed-based treatment programs might offer. This is a frequently requested option by patients, and it may still be beneficial for some patients. Turning to harm reduction and safer use strategies, in taking up a client-centered trauma and evidence-informed approach, discussing safer use strategies with clients is recommended. For many people, abstinence may not be possible or preferable goal. Working alongside with a client in their goals will support building trust and breaking down shame and stigma. We should ask patients how they keep themselves safe and offer tailored education and services. We should inform patients of the risk of fentanyl contamination of illicit stimulants and encourage drug checking and avoiding using alone. And this is some Q&A questions here as well. Let's see here. A question regarding contingency management. Would the CSU provide any recommendations or support conversations with the Ministry of Health regarding sustainable funding for evidence-based psychosocial treatment for stimulant use disorder? I know there are 1 or 2 pilots in BC Asian Island Health exploring this. The issue always seems to come down to sustainable funding for contingency management. Wonder if Dr. Back might have some comments on the question.
Yeah, I mean, I can speak to that a little bit. These are always challenging discussions. I think that, as Julius has highlighted, contingency management, which for those who are less familiar with contingency management, is based on the principles of operant conditioning. It involves programs where small rewards are in place to help promote behavior change. And is by far the best evidenced and most cost-effective treatment we have for stimulant use disorder. There are a variety of there are a small number of contingency management programs available in the province, and they're all funded kind of. It seems to me at least a little bit of an ad hoc basis, and funding is sourced from a variety of different places. Certainly, this is something that I would be happy to help continuing to advocate for. Probably what I would suggest would be, if this is something that anyone has an interest in trying to establish in your setting, would be to reach out to us to see whether we can help facilitate that conversation in any way, because there's a variety of potential avenues, unfortunately none of which are guaranteed. But it's contingency management not only is the most effective treatment that we have, but it's also so easy to establish these programs. Something like CBT, as Julius has alluded to, takes a lot of training and a fair amount of time. But a contingency management program, you need a rewards, and you need a space to hold them in. They're not particularly complex. And so I would encourage anyone who would have an interest in setting something up to reach out to us after this talk, and we'll see if we can at least connect you with somebody who might be able to help with that discussion.
Thank you very much. I wonder, Kat, if you have any thoughts on the more psychosocial treatment, such as contingency management or CBT or bed-based programs or peer-led programs as well.
Oh, I definitely, yeah. I think peer-led programs is like the ultimate number one. I think it's absolutely important. Peers know, they've been there, they know what they need, they know what helped, they can help each other. And it is kind of like, it gives them purpose, it gives them a sense of hope. I mean, a lot of, there's support. I think peer-led, it at least connecting with some type of peer support or peer-led organization would be the ultimate. I totally agree with the contingency program. Again, it gives them a sense of like something to look forward to, a bit of hope, and it feels good, right? It feels good getting something and looking forward to something and getting it, because that seems to get taken away throughout the stigma and discrimination of people who use substances. And I think for the lack of beds for stimulant use, or even like access to prescriptions, I absolutely agree there needs to be more. I've heard of people who, use opiates just to try and get on stimulants because that was kind of the protocol, or the same thing with detox, or, treatment where they had to have that dirty drug screen, which again puts them more at risk. So those are my brief comments on those three subjects.
Thank you very much. And with that, I'll turn it over to Paxton to talk about prescribing stimulants to reduce overdose risk and other harms.
Great, thanks, Julius, and thanks for that introduction to some of those evidence-based treatments. Again, lots of opportunity for a Q&A at the end of this session to ask any follow-up questions on anything that he's already touched on, and a lot of that is explored in the document itself. Moving into the second part of the presentation itself, we're going to talk a little bit more about prescribing of stimulants to reduce overdose risk and other harms, also known as safer supply prescribing or risk mitigation prescribing. Oops. So to be clear, this is maybe a bit of a philosophical question or observation. So as Julius mentioned, there is evidence for the use of psychostimulants for the treatment of stimulant use disorder. More commonly in the context of cocaine use, but there is some evidence there. But what we're talking about in this section is more through the lens of risk mitigation or safer supply, and so I think that that does influence this conversation a little bit. But this remains a bit of a gray area because you could kind of look at them as treatment or safer supply depending on how you want to frame this discussion. Dr. Elefante did mention this trial earlier, and I'm just gonna reiterate that there was a very thought-provoking meta-analysis that came out in 2020 that really, I think, opened the door for a lot more discussion on the utility of prescription psychostimulants. This study found that prescription psychostimulants were effective at promoting sustained abstinence from illicit stimulants. So again, a very high bar to set for these trials, but they actually found that it was effective for promoting sustained abstinence with a number needed to treat of around 16, which is really encouraging. However, I will emphasize that the vast majority of patients included in this meta-analysis were pulled from trials that were looking at cocaine use. So how well this applies, through the evidence-based lens, how well this applies to amphetamine use disorder and methamphetamine use disorder is still up for debate. That being said, as everyone is aware, we've had some experience over the past 2 years, some increased experience using prescription psychostimulants for risk mitigation in the context of COVID-19 and risk mitigation prescribing. My clinical experience and that of many of my colleagues, I would say, suggests that prescription psychostimulants have a relatively limited benefit for people who use illicit stimulants. I haven't found an overwhelming response to these medications, but that there's a significant minority of people who report a benefit in terms of either reduced reliance on illicit drug supply or perhaps just safer use or overall improved functional or social outcomes. And it's just a reminder that that abstinence or even reduction in use is not the only important outcome to mention here. Kat's already alluded to this, but maybe I'll give her the floor again to just talk about her experience with risk mitigation prescribing and psychostimulants.
Thank you. Like I mentioned before, especially like from crystal meth, you actually do go through like a pretty hard withdrawal. It's very real. So for me, the safer supply helped manage that. It helped me reduce. I needed to, I did it in a way of like, kind of like a microdosing. And so, but I had a really good relationship with my prescriber. And again, like I was able to be open and honest with her. And by me, my goal was to reduce and eventually get abstinent. And she worked with me on that. And so I microdosed and I started using more of the safer supply and less of the crystal meth. And I was on both, and I did the Dilaudid too. So and the fentanyl, but I noticed because there's so much toxicity within the drug supply that I needed to do that personally. Because I was having such a hard time withdrawing from a lot of the benzos and whatever else was in there. So that worked for me. I also needed to like have a combination of like fast release and along with the slow release. So that's why I mentioned before, like depending on, like you really need to work. I would highly recommend working with your patients on what they think is going to work for them. And I also believe that prescribing it is safer than them using the toxic drugs. So and yeah, the harm reduction, like if you know that if it's somebody wants to cut down from pulling 10 Jones or dates a day, or selling themselves down to like maybe 2, that's a huge harm reduction, and it's a huge improvement to quality of life. If somebody wants to start using less or only spend $40, and then how do you get there? What are you going to need to get there? The risk mitigation, the harm reduction, I'm saying risk mitigation, sorry, that the harm reduction piece is just as important as, because that is in a way of leading to abstinence from the toxic drug supply. And I think that's the goal, is trying to put something that's more safer in the body than rather than, putting that at risk of this might be the time I die.
Thanks for those comments, Kat. If there's 2 things that I'm hearing you say that really that resonate with me, that I always really stress, it's one, that safe and honest and collaborative relationship with a prescriber, because this is not easy, and that flexibility in outcomes, and trying to figure out how might these things help, and not being so rigid as to think that abstinence is the only potential benefit from this type of prescribing.
Yeah, and I also like to say, like, a lot of people, it takes a lot for people to come through those doors. And I say this because there has been so much stigma and so much discrimination, and that internal stigma, like it festers within inside a person, and without, so to walk through those doors, and then if they don't, have a good connection and start building a good relationship and feel like they're safe, feel like they might actually get somewhere and somebody actually cares and they really want to help and they're going to work with me, when they don't feel those things, the chances of them coming back through those doors are really slim. And that's harm reduction all on its own.
I think that's another really important message, Kat. I think for anyone who's in the audience who has not had experience with prescription psychostimulants, or who's sort of on the fence about whether this is something that you want to incorporate into your practice, I think this really summarizes the current status to me, is that based on the limited signals of efficacy in the literature, and I will highlight those that are quite limited, and the clinical experience showing that some individuals may benefit and reduce their risks or improve the quality of life in various ways. This is emerging as a practice option that may be appropriate to trial in certain situations, but it's really important to have a thorough risk-benefit analysis, a thorough discussion on what we know and what we don't know with patients, because these are medications that can potentially cause harm as well, and really have that discussion, and weigh all those risks and benefits as well, including potential benefit, potential harms, in deciding on how to proceed. The nice thing about these medications is that if you do go down this avenue and you're not finding benefit from them, as Julius has already highlighted, there are many other tools to look at, and this doesn't have to be the be all end all. So indications, as from the perspective of this guidance document and our previous risk mitigation prescribing document, is anyone with ongoing active stimulant use who is at high risk of overdose or other harms related to illicit stimulant use. Given the potential harms that we already highlighted early in this talk. I think anyone who's using stimulants in this province is currently at risk of overdose and other harms. So really ongoing active stimulant use in our current environment is the only is really the only meaningful eligibility criteria. We've gone into some detail in this document around suggestions about initial assessment and follow-up. This is all documented in the practice guidelines. So I'm not going to go through this in a huge amount of detail, other than just to introduce kind of these concepts. This is the recommended all the recommended items in your initial assessment, which are very much consistent with any addiction medicine consultation. I think I've highlighted two here in bold that I just want to speak to specifically, because and Kat's already mentioned this. So I think these are really important pieces of this assessment to really emphasize. And first off is establishing what an individual's goals are and who's trying to initiate this kind of treatment, and secondly, what indicators of benefit are we going to use to assess whether we're making progress. And I say that because it's much easier up front if you've decided on what metrics we're going to use to see whether this is helping. That may be a reduction in use, that may be less presentations to hospital, that may be improved quality of life, or a variety of measures. It may be abstinence, but setting those goals up front so that you can check in on them regularly, I think really help make these assessments easier. The most common questions that come up when we're talking about this kind of prescribing is, what are the cautions and contraindications, which I think is very valid. And this is something that I'm glad Julius is on this call to speak to this as well. But this is a really difficult question. The most common contraindications are these. So a known diagnosis or indications of psychosis or past significant mental health diagnoses, pregnancy, or the third one that's not on here is significant cardiovascular disease. And I think that there's no easy answer to these questions, other than in my experience and my suggestion, and I'll open the floor to Julius to give his input here as well. But I think that really trying to engage as many members of somebody's network and healthcare team in discussions on whether it's worth trialing these medications is important. So I think speaking with their mental health team or psychiatrist, speaking with primary care providers, speaking with anyone else involved in their care, and coming up with a plan together, and having a pretty frank risk-benefit discussion with the patient is all part of that decision-making process. There are very few scenarios where I'm absolutely unwilling to prescribe, but certainly I think we do have to proceed with caution because we know there are potential complications. Julius, add this if you have anything to add to that.
Thank you. I think I want to echo what you said about having a really thorough risk-benefit assessment with each patient, because every patient is different. Any patient with schizophrenia or bipolar disorder, they're not all the same. The bipolar disorder might be milder for some, or the schizophrenia might be milder for some, and for some others it might be more severe. So depending on what their risk is, it would be more difficult, say for instance, to start somebody on psychostimulants if they have uncontrolled psychosis from schizophrenia that they're not on any other medication for. So say, for example, they have untreated schizophrenia, they're currently psychotic, and they're at risk for harming themselves, then that would not be probably the time to kind of start a psychostimulant. You might have to stabilize the psychosis first. When the risk-benefit assessment kind of points to the fact that perhaps the risk is much higher from inadvertent overdose, from the street supply, then that's probably when I'm much more inclined to start trialing a psychostimulant to see if that might lead to some reduced use. In anybody with a primary psychotic disorder that's already established, I always recommend having treatment for that disorder as well. So yeah, I think that helps kind of reduce the possibility they might have some psychosis down the line.
I think the important, or go ahead, Kat.
Sorry, thank you. I think that if somebody with either one of these three symptoms that you mentioned or cautions, I think that they're coming through the doors and they're asking for help. That needs to be acknowledged. And I think that looking at the risks, is my prescription going to kill you? Or is you walking out this door and going to use next going to kill you? What's the higher risk there? And if it has to do with, psychosis or, needing some previous meds or new meds, that it could be approached in a way of, I want to do this with you. I would like to do this, but I need this, I would like to see you do this as well for these reasons. Because if, you're coming in, they're coming in asking for help, right? They're coming in saying, I want to live. I don't want to die, basically, because that's how it is out there now. So, if you approach it in a way of like, I will do this for you, but I need you to do this for me so that we can succeed, and explain why you think this is going to work better for them with the psychosis stage, then that would be my recommendation. Same with the pregnancy. I honestly think that a prescription is way more safer than, using. And again, that I just see so much higher risk using the toxic drugs. And with the cardiovascular, the same thing. It increases your heart rate insanely. So I still see it more of a risk not to walk out that door and go use rather than try and work with that. Those are my comments.
And I completely agree. I think, yeah, just like make sure you're working with each other is really the key here, and trying to figure out the best way forward. There is no easy answer to these questions. But if again, calling 24/7 a race, if you ever just need to talk through a case, is we're always there. We're always a resource that can be used. And this is speaking to the contraindications as per the label of these medications, which is pretty similar to what we were just alluding to here. So another common question is, how do we prescribe these medications? How do we initiate? How do we titrate? What does the evidence tell us? And how should we be prescribing these medications? And unfortunately, again, we know quite little. And so, I'll talk about my approach, but again, I really emphasize a collaborative approach with a patient, discussion whether they've ever tried these medications in the past and what's worked for them in the past, and kind of going down this path together. So the two psychostimulants with the most evidence supporting their utility but also safety are dextroamphetamine and methylphenidate, which is why they're the two that we have included in this document and talk about the most. For dextroamphetamine, the starting dose is recommended in the range of 10 to 20 milligrams of BID as a starting dose, but certainly can be up titrated from there. The maximum total daily dose we have recommended for the purpose of this document is 40 milligrams twice daily, or 80 milligrams as a total daily dose. And that's the highest dose that we can look into the literature and document at least relatively good safety to. I will say that some prescribers have exceeded this and find going even higher than this to be successful, but that's the limit beyond where our safety data will take us. I will say that the best available evidence we have around efficacy suggests that doses of 60 milligrams or higher, 60 or higher as a total daily dose, are more likely to be efficacious. And I think that's not a surprise that when we're trying to compete with powerful psychostimulants such as crystal methamphetamine, that higher doses are often needed. The other thing that I will stress and that I do is often talk to people about whether or not they're about sustained release versus immediate release, and what they think will be most helpful for them, about what they're looking for from their medication. And you can try one or the other, or combinations of the two, and adjust accordingly depending on what an individual is finding helpful. There's no clear recipe for what's effective here, and the exact same approach for methylphenidate. So the total maximum daily dose that's recommended is 100 milligrams within 24 hours. But how you get there, I think, is again it's about collaborative decision making with a patient, and figuring out what works best for them. Kat or Julius, if you have anything to add to this.
Sure. Oh, you go ahead.
Oh, go ahead, Kat, and then I'll.
Okay, I just wanted to say that I think the combination, like just really look at that, and for a couple of reasons. It could be just as much as like a part of that placebo effect where it's still in the mind, right? So that slow release is there, but having like a fast release too, and that instant, you know, and feel that they're using or they're putting in them and they're going to have a fast effect. And, you know, while they're trying to stabilize from this slow release is really, I just really want to echo that combination really works for a lot of people. So looking at combinations and really working with them, like, you know, that might not be them, but work, that might not be what they think is going to work for them. But if they say that, you know, this is what they'd like to see, or they've heard that this works for other people, I think is to, again, like Dr. Paxton said, really working in a collaboratively with your patient on what they feel is going to work for them, and trying new things. If they come back and say this isn't working, instead of, you know, well, that should have, or having that a different type of frame of mind, be open and be like, okay, what else, you know, what would you like to see? Or these are the options, but, you know, like really making it feel like it's a fair play, like level of working together, I think is important, because there's that, again, that stigma and discrimination, that internal stigma that they hold in there. And if they feel like, well, it should work for you, or, you know, they feel like they let you down even in a way, I think it's really important to just be mindful of your own language that you're cutting off of to build those relationships and to start like working into like what the trials and errors. I just wanted to mention that.
Thank you, Kat. And I think what I'm taking from what Kat's been saying all along is really working with our clients, our patients is really quite important. And when I'm doing safer prescribing like this, I really have to make this cognitive switch for myself, that I'm not imposing abstinence. I'm actually trying to meet them for what their goals are. That if they say they want to try to use this in place of the meth, and they want some immediate release medications, then I'm willing to give it a try for sure. But it does take, for me as a practitioner, that extra step of thinking, okay, I am not supporting this client for abstinence, but I'm supporting them for how they want to use it in a more safe way.
So nearing the end of this part of the presentation, but again, just reiterating that medication selection should take into account patient preference and the current use patterns, and certainly I found some people who do really well on slow release, and others who would do better on a combination of the two, and many who have just not found these to be particularly helpful, and we devote our energies elsewhere. Similarly, frequency of dispensation should be also guided by clinical judgment, prioritizing both an individual's safety as well as community safety. You know, this remains a part of sort of the addiction medicine framework, and so daily dispensing is generally what is recommended, but taking into account patient considerations and local geographic contexts, I think, is really important. You know, as long as you're being safe and thoughtful in your decision making, then clinical judgment really does, I think, supersede everything else. The last thing to touch on is just how to assess benefit in continuing care, and this is, again, I'll go back to that idea of you know, trying to set those markers of success up front and figuring out, you know, in what areas would we like to see benefit. I think is really helpful when you're trying to come back in a couple of weeks to see whether these medications have been helpful. So recommending a trial period of a couple of weeks. I think Kat has already alluded to the fact that her particular journey took some time, and so expecting a result within a matter of days is not always realistic. But taking some time and doing a thoughtful reassessment in a couple of weeks, deciding at that point if we want to continue on with this trial or not, I think is fair. And if assessment indicates that somebody's not benefiting, it's fine to reconsider whether this is the right medication for them, whether it's the right dose for them, or perhaps it's just is not speaking to what their needs are at this time. And again, it's better to devote our energies elsewhere. So really, again, it's about that relationship between a prescriber and a patient. there are a variety of indications that have been included in this document that might suggest somebody's benefiting. I think that this is by no means an exhaustive list, but certainly reduction or elimination of illicit stimulant use is a fairly easy one. But reduced overdose risk or reduced presentations with overdoses, reduced cravings, improved quality of life, reduced need to engage in high-risk activities. These are all just as meaningful, if not more meaningful, than simply the dichotomous abstinence versus not abstinent. Similarly, indications that somebody's not benefiting are just sort of the corollaries to this, and with a particular emphasis on worsening mental health issues or physical health conditions. This is a note for any a reminder for prescribers and also for pharmacists, just to reiterate, for all of our safe supply prescribing, whether you're hydromorphone, mescaline, dextroamphetamine, whatever, if you can just denote on the prescriptions the acronym SA for safer alternative, that is purely for the purposes of evaluation. So there's a large provincial evaluation ongoing, looking at all this prescribing, and in order to help tease out what prescriptions are written for what purposes, this is very helpful in facilitating that evaluation. So denoting SA on your scripts is extremely helpful for us, for the evaluation team. That is really the extent of what we're going to talk about today. The introduction of the document, that does give us plenty of time for discussion. I will put in one more plug. I'll continue to recommend 24/7, but anytime that you have questions around this prescribing or complex cases, even if you're not looking for an easy answer, but just somebody to talk through a scenario with, we're available 24/7. So please keep this line in mind. I hope you find it a helpful resource, and call often. So for the purposes of, go ahead, Kat.
I just want to make a comment on the daily dispensing, or like the pickups and like the challenges or barriers that can create. I think that when you're working with your patient, it's really important, and their support system, right, or team, I think it's important to bring that up as well. And I mean, like, that could look at like looking at the pharmacy, making sure that they feel comfortable going there. There's a lot, again, that stigma and discrimination, right, that follows, and that we see that a lot, and unfortunately in a lot of different pharmacies. So that daily dispense, like having to go in daily, can be very challenging for many other reasons. It could be health reasons, it could be they just forget, so just what are those challenges, barriers, and where do they need support, and how do we help them succeed? Because I think it's unfair to just write a prescript and expect them to fully be able to do everything on their own without that being identified within like your assessment or whatever, if they would need support and what that might look like. And if that looks like maybe having a weekly pickup or once every few days, then I think that should be looked at, and not approached in a like thinking, assuming that that's that, oh well, this could, I don't know, I just see so much discrimination around that, or it feels like that anyways. I know there's like risks to prescribing, but it feels that way, and it feels that way for them, which can also give them the switch that frame of mind of like, fuck it, there's no point, because like there's a lot of shame in there. And I think that so maybe looking at or if there is a support system that can pick them up and drive them, is there maybe an outreach team that can deliver, and their name is mentioned on the script, or whatever that looks like. I think that these all need to be identified as well. I probably went into that a bit longer than I should have, but
no, thanks for that, Kat. I'll just go through, just for the purpose of a recording, these are the variety of references used today. But with that, I will just ask everyone, please, questions and discussion items, put them into the Q&A tab, and we are happy to I'll stop the screen share so you can see everyone at this point, and we can take questions from the audience.
Perfect. While people are putting their questions into the Q&A, I have a couple that came through on our registration page. So thank you if you put your questions in ahead of time. One that we didn't quite get to speak to in the presentation today was, does a diagnosis of ADHD change the approach to treating stimulant use disorder or prescribing stimulants? Does anybody want to take a crack at that one?
Thank you. I think if somebody has diagnosis of ADHD, they should get treatment for their ADHD, and that can include psychostimulants. A lot of practitioners are uncomfortable with this. I think part of the reason for that is there was a recent practice change. Up until 2014, the ADHD guidelines in this country kind of said, if somebody has an active substance use disorder, you cannot diagnose ADHD. In 2018, that changed. The current recommendation actually from our guidelines is they should get treatment for both conditions with the appropriate treatments for both, basically. So give the substance use disorder its own treatment and give the ADHD its own treatment together. The guidelines also say that sometimes if the substance use is severe, you could prioritize the substance use treatment first. But I think a key change is, yes, absolutely treat both. Yeah.
Can I make a comment on that? I think that with my experience, and I speak for a lot of people here, I think most people who use substances probably have ADHD. And I also think that safer supply is a stepping stone to possibly being diagnosed and eventually treated for it.
And thank you very much, Kat. Yeah, and what Kat had said, how common it is, it's actually supported by our data. I think the rate of ADHD for somebody who does not, for people who don't have substance use disorders is about 5%. In people who have substance use disorders, it's about 25%, so 5 times higher. So there's more ADHD in people who use substances for sure. Yeah, and ADHD itself is a risk for substance use. So it's a very enmeshed relationship between those two conditions.
And I also find people self-medicate and using stimulants is their way of treating themselves by medicating their ADHD, because it helps them focus, it helps them calm. So I think just by the different highs, you can almost tell who's ADHD and who's not, because by using stimulants, it like I said, it helps them focus, it helps them sit still, it helps them calm, it helps them accomplish things. Whereas somebody without ADHD, it does the opposite effect. It hypes them up, it agitates them, and it gets them like flying. So I just wanted to make those comments about that.
Great, thank you so much, Kat. I have a couple questions trickling in here to the Q&A. In regards to the thorough risk-benefit analysis for prescribing psychostimulants for stimulant use disorder, are there any rating scales and/or tools that might be in development for this to guide the assessment of risk and benefit for prescription for practical application in practice? Does anybody know anything?
I can speak to that. No, we're not as far as aware, and I wouldn't expect anything anytime soon. As mentioned, if we're going if we're looking at the current literature in this area, the efficacy of these medications in all comers is not clearly established, particularly for methamphetamine use. So, in the absence of solid data suggesting that this is even a widely effective intervention in all comers, that's a pretty nuanced tool in question that I think we're unfortunately will be some time before we start to see that level of sophistication in our ability to approach these cases. So it does just take a thoughtful assessment, a lot of collaborative decision making, and an honest discussion on risks, and a lot of close follow-up.
Great, thanks, Paxton, for weighing in there. Back to ADHD, another question came in. Any wisdom on making that ADHD diagnosis in patients using substances? Is it all looking into childhood behaviors?
Thank you very much. So ADHD, the way we think of it right now, is it's a neurodevelopmental disorder. So meaning the symptoms typically start in childhood. whether or not it's noticed in childhood can be quite variable, right? Because standard ADHD diagnosis does include information from parents, but many patients who come to us might not have family anymore who might be able to provide that information, or perhaps might not have had the same attentive care that some children might have. The parents kind of focus on their behaviors. So typically we do look for evidence that there's been some inattention that start from childhood, because it's a neurodevelopmental disorder. But it's also can be quite complicated, because there are some patients whose ADHD might not be severe enough to be noticed in childhood, but they might be noticed a little bit later, say at age 12 or around that time, when there's a lot more need for higher level performance in school. So maybe that's when the inattention symptoms might show. Yeah. So typically in a standard ADHD assessment, we'll look for evidence that it starts in childhood. Yeah. Some people can say, you know, oh, based on their response to stimulants, you can decide on that. It's not necessarily how we do our assessment, because people with ADHD also report benefit when they have stimulants on board, which is why a lot of college students will borrow ADHD medications from their friends with ADHD during exam time, because it does improve their concentration as well, even though they might not have ADHD in themselves.
I've seen people like not have ADHD when they were children, but later on, after many years of use, developed ADHD. So I'm not a psychiatrist, but I've seen that happen. So
yeah, the symptoms of ADHD can look like many different things, and many factors can lead eventually to developing symptoms like ADHD. But the illness of ADHD itself is the way it's thought of right now is it's something that stems as a neurodevelopmental disorder from childhood. But of course, you know, traumatic experiences, depression, anxiety, substance use can also lead to symptoms that can look like ADHD as a whole. So that can complicate the assessment too.
Such a tough thing to tease out. So thank you so much for both of your contributions there. I know a lot of healthcare providers have difficulty kind of navigating those waters a little bit sometimes. We have another question here. What are your thoughts on detox programs not accepting stimulant users, given the contamination in the drug supply / user experience Kat mentioned?
sorry, what are my thoughts about like having to not have like other substances other than stimulants to go into detox?
I think that's kind of what the question is asking. Yeah. What are your thoughts on? Sorry, go ahead.
Sorry, I think it puts people more at risk. I've seen people literally, I mean, it's hard enough. There's so much barriers and challenges already to try and get a detox bed. Especially if you're homeless, you don't have access to a phone, you're supposed to be calling every single day. You can't have somebody else call for you. It has to be you personally. And then when you finally get that lucky call, you have maybe 10 minutes sometimes to be there, which is another challenge, or else you lose your bed. And then if like many people who are using stimulants want to go to detox and you know, I've seen them using in case they get that bed, and now they've developed another habit. Or if they have 10 minutes and they don't have enough time, and then they get up there and they don't test, you know, they only have the stimulants, then they're turned away. I think it is insane. I don't know if it's because they don't understand that you actually go through physical really bad withdrawal if you're using a lot, especially with all the like the toxic adulterants that they're adding to the drugs. I think there needs to be more access to detox beds and treatment beds for stimulant use for sure. Yeah, it's dangerous not having it. That's all I can say.
I would support that. I think it's just a critique of our system as a whole in the province, if we can call it a system. I think that my question for anyone who approaches me, whether they're in hospital or in the emerge or the clinic going to detox, is really like, what do they want from detox? Because the reality is, for a lot of people, they don't actually want detox. It's just the only pathway into the treatment system that they're aware of, or realistically that exists. And so for some, if somebody doesn't actually want it to, doesn't need to detox, but is simply looking to access the system, then sometimes you can help redirect, although truth be told, that still may be the quickest avenue to access the system. But as it does depend on what they're looking for. And as Kat's mentioned, withdrawal from stimulants can be quite profound. And if somebody is homeless or unstably housed, crashing from stimulants in a shelter or on the street is not only inhumane, to put it at the least, but is potentially very dangerous. So as a blanket statement, somebody not being able to access detox for stimulant withdrawal, I would say, frustrates me. I don't know where that question is coming from, and I'm not sure but I'm sure that's a barrier that does exist. But I also recognize that detox beds are vastly under resourced, and they really are trying to allot them to those who quote unquote need them the most. And so it's just more of a criticism of the system as a whole, but that's even a discussion point.
Mm-hmm.
Yeah, it's unfortunate, the state of the availability of some of those services right now. There's no questions in the Q&A right now, so I encourage anybody who's still tuned in, pop your question in there. I've got one more question from the pre-registration that came through that I can.
There's one in the chat box here as well, Rebecca, I think, around how much of this guidance, how it applies to pediatric populations with severe stimulant use disorder.
Great. Yeah, I actually can't see that. So go ahead and
that's in the chat box, not the Q&A, but which is a really great question, and another one without any easy answers. I guess for the purposes of the guidance document, it's clearly stated that being under 18 is not an absolute contraindication, but certainly there are additional considerations, I think, with youth populations. And it also is going to depend very much on where in the province you're working and what resources you have available to you. I would say that, to me at least, I should preface this by saying I don't work with youth populations. I work in an adult hospital, and I'm an internist by training. But I think that the approach does remain pretty similar. But there are different resources and considerations available out there for youth populations in many settings, and really taking a look at psychosocial interventions and social determinants of health and other potential contributors to stimulant use, I think is always critical, but maybe even that much more critical in a 16-year-old. I don't know, Julius, do you work with any youth populations? Do you have any pearls of wisdom?
I also don't work with youth in 12 to 18, so I don't have. It's a good question. I just don't have any answers. It's not a population I work with. Yeah.
I know for up here, there's very minimal help for youth, and it's really frustrating because I see over half our street population, it feels like, if not at least half, all under the age of 19. Over the last 10 years, it's not even like 6 years, it's really it's heartbreaking, because there's so much youth who are addicted to crystal meth and are struggling because there's no resources, and because they are youth, it's hard for them to get prescription. It's hard for them to go hit shelters. It's hard for them to go to OPSs to use safe. It's really challenging, and I know for me personally, I would love to see somebody being able to offer some type of treatment for our youth. So,
you and me both, Kat. I have one more question I can put to the group here. What is the value of urine drug screening in providing care for someone living with stimulant use disorder? Anybody have thoughts?
What was that?
Yeah,
What was
I mean,
the
what's the value of urine drug screens? I would say probably pretty minimal in my experience. I think that we overvalue the utility of urine drug screens in general in addiction medicine. They don't really give us a lot of information you can't get by just asking somebody. You know, there's certainly many issues associated with performing them. I think that, you know, I think that this is a bit of a tangent to that question, but one thing to keep in mind is that you know, when people use stimulants in very different ways, in very different patterns, and it may not be daily use, that people may go in binges like on weekends or 1 week a month. And that certainly doesn't reduce their risk, and it actually may increase their risk of an inadvertent overdose. So just because somebody's urine drug screen is negative for stimulants, by no means does that mean that they aren't potentially eligible for such a program. And similarly, the utility of checking urine drug screens to somebody who's on treatment is also pretty questionable. First off, if they're on dextroamphetamine, they're going to be positive for amphetamines anyways. But secondly, that is a pretty you know, the presence or absence of a positive urine drug screen is a pretty crude assessment of benefit. Right? That's really focused on abstinence as your sole outcome. And so you're missing out on all of those potential benefits that we've talked about already. So there's really the biggest utility that I would say in my practice of a urine drug screen for somebody who uses stimulants exclusively is seeing whether they're inadvertently being exposed to anything else, like fentanyl or benzos, because we're well aware that such a thing can happen, and that can be really eye-opening, I think, for an individual who doesn't think that they're at risk of fentanyl exposure and finds out that they actually have been already. Can be quite scary.
Yeah. In my work, I think I agree in general, the utility is quite limited. Perhaps one of the places where I might find it helpful if I'm meeting somebody for the first time who's got psychosis in the emergency department and we're not quite sure what the psychosis is from, that might just add a little bit more data where it might from. I mean, it still doesn't say it's just from the amphetamines if your urine drug screen is positive, because they might still have other things, but at least it's just one more data for us to consider. But in general, I do find it limited also in terms of usefulness.
And I think it's important too to like I agree with both of them right here, Paxton and Julius, absolutely 100%. I think I just wanted to comment on the internals, like from a peer's perspective, being asked for drug urinalysis. I think it's important to explain why you want it, and that is not coming at you know, I expect you to be abstinent approach, or you know, there's consequences if you know I'm finding this in your drug screen. I think it's really important to express that, because I've seen people not go back to get prescriptions just because of the way they feel stigmatized or judged or going to be punished or, you know, cut off, or their dose is going to be reduced because they have something in their system.
Yeah. Definitely should not be used in a punitive way, for sure. Yeah. So, and that's been unfortunately the experience of many people, as you pointed out, Kat. Yeah.
Mm-hmm.
I'll also point out that because people may not use stimulants every day, to expect them to take their prescribed psychostimulant every day is also potentially may not be the appropriate treatment regimen. So if somebody was to have a negative urine that you were expecting to have amphetamines in it again, that does not mean that they're not. That does not mean that they're necessarily taking this inappropriately. If somebody is using 2 days out of the week, I very likely don't want them to be taking this medication every single day. So again, there's certainly no substitute for just a conversation.
Yeah, that's great. Thanks for adding that, Paxton. I've certainly in my practice seen the urine drug screens used in that way to confirm that people are actually taking the medication that's being prescribed, but it's not necessarily the best way to manage that. Last call for any questions at all into the Q&A. I will open the floor to all of our speakers here right now. If there's any closing remarks that you wanted to make, and also just thank you all for being here today and for sharing your knowledge with everyone. I really appreciate it. And I'll go ahead and open it up if there's any last closing words here.
I can start. I'll just again thank the audience for coming. I want to reiterate: stimulant use disorders are a treatable condition. We tend to focus on them less than conditions like opioid and alcohol use, where we have more evidence-based pharmacotherapy, but we have evidence-based pharmacotherapy, we have evidence-based psychosocial interventions. Number needed to treat for contingency management is somewhere between 2 to 4, so really excellent number needed to treat. So they're not something to shy away from. I think we need to try and do better, especially considering how the numbers are climbing. But it's painfully obvious that many of our gold standard treatments are very, very difficult to access in our province. So to Danny's question from earlier, ongoing advocacy for more access to cost-effective, evidence-based treatments is really critical moving forward.
Thank you very much. I'll go next, I guess. Okay. Thanks, Paxton and Kat, for sharing this space. I guess if we have any take-home points, is it's been said over and over. We really need to meet our patients where they're coming from and to support their goals. And also from the work that I do, I really want to impress upon our audience that many of our patients not just have a stimulant use disorder, but they have other needs as well, mental health needs, social needs as well, that should be looked upon holistically.
Thanks, and I'll close it off. So I think that any last notes would be, I think it's really highly beneficial if you're able to connect with a peer-led organization, to work with peers to help build those connections and relationships, and a support system. That might be just that bridge that kind of needs to, the way of building that bridge to make those connections, and that support system and moving forward. I also, I just went blank there. Oh yes, I also think it's really important to get to know your patient, get to know who they are, let them know that you know, and build those relationships. I can't echo that more. It's so important. Don't, because they pick up if they're just another appointment, or they might feel like, just being really mindful of body language, tone of voice, and letting them feel safe, I guess, is the keys to building those relationships and starting a good journey between you and your patients down the trial and error road, because it's going to be trial and error, but it's saving lives. And I think just looking at those risks of how toxic the drugs are out there, and this is stepping stones towards the right direction within this toxic drug supply and crisis.
Great, thanks so much. Thank you again, everyone. Dr. Elefante, Kat Cadieux, and Dr. Back for being here today to share your expertise with the group. Just a reminder for everybody, this session is recorded. We will be sending it out later to registrants. We're going to go ahead and put an evaluation survey in the chat right now as well, and we'll also email this out. And again, just thanking everyone for their time and for being here today. And on that note, we will go ahead and end our webinar for today. Thank you so much.